My name is Ida Sadhu, and I am the host of ADBCC, the People's Residence TV. We can say that now with confidence. And we're located at 777 Bathurst Street, but because you can't come to us, we are coming to you in the comfort of your home. And I hope that you are all, for those people who are online, I hope that this is going to be a great session for you. Feel free to send us those questions as we engage with an incredible scholar, Dr. Keith Wailoo. And people you who know me, you know I get excited about things, but I'm particularly excited today to welcome Dr. Keith Wailoo to ADBCC, the People's Residence Conversations here at noon. I feel as though I've known him for a million years already, just because I happen to know other people with the same last name. And for those of you who don't know who this incredible scholar is, Dr. Keith A. Wailoo is chair of the Department of History and jointly appointed in the Woodrow Wilson School of Public and International Affairs. His research straddles history and health policy, examining drugs and drug policy, the politics of health and healthcare, the interplay of health, ethnicity, gender, and identity, and controversies in genetics and society. Now, I've said a whole lot of things, but it just doesn't stop there. He's also documented, and he's the author of Pain, A Political History, How Cancer Crossed the Color Line, The Troubled Dream of Genetic Medicine, Ethnicity and Innovation in Tay-Sachs, Cystic Fibrosis, Sickle Cell Disease, Dying in the City of Blues, Sickle Cell Anemia, and the Politics of Race and Health. Before joining the Princeton faculty, Professor Wailoo taught in history and in social medicine and at Rutgers University, where he was affiliated with the history department and the Institute for Health, Healthcare Policy, and Aging Research. He holds a PhD in the history and sociology of science from the University of Pennsylvania and a bachelor's degree in chemical engineering from Yale University. A big, big welcome to you, Dr. Keith Wailoo, and how are you today?
I'm doing great. Thank you so much for the invitation. Glad to be here chatting via Zoom and Facebook.
There's so much going on. I just want to say that we've brought Princeton into Canada. Princeton today and yesterday also broke news. The first Black valedictorian, Nicholas Johnson. In the 250 years history of the university, we have the first Black person to be the valedictorian.
It was a big news here. Yeah,
it's big news because what made us excited here too in Canada, he has a Montreal connection. So of course, Canadians are saying, smart because he was trained in Canada first.
Everybody should take credit. Everybody should take credit.
Definitely taking credit for him and for you. So this is a significant day too that we will be speaking to you with this breaking news. And I also know that you're hot off the weekend's conference where you hosted the American Association for the History of Medicine. And over the weekend, you looked at pandemic, creating a usable past, epidemic history, COVID-19, and the future of health. That's a whole mouthful. But Dr. Wailoo, I want to ask the first question. What do you do for fun? What's your favorite music? And how has your Guyanese ancestry influenced your work?
That's a great, those are three good questions, not just one. So what do I do for fun? I like to cook, which is connected to how my Guyanese ancestry has influenced me. I like music, which is also an example of how Guyanese culture and my background has influenced me. I play piano, but I like jazz. So I try to work on music, and I like to run, do cross country. in terms of how my Guyanese background has influenced me, I mean, I think that I've always been interested in the way that issues of race and ethnicity have informed and shaped society, and how it these kinds of controversies around race have an impact on people's lives. And maybe that goes all the way back to, you know, we emigrated from Guyana to New York. I lived in Toronto for a year when I was 7 years old. And, you know, when you're 7, you know just enough about the place you come from to try to grapple with this new place, North America, Canada, New York. And I like to think that as an immigrant, I have been trying to make sense of living in the United States ever since I was 7 years old. So that's 50 years ago, right? And so I feel like it's more the immigrant experience of knowing something that is new and knowing you have to try to figure out what the logic of this place is. So in that sense, I think I've been a student of American and North American society ever since I was 7, out of necessity, right? You have to learn how to speak differently. You have to learn what these customs are. You have to learn these attitudes because you have to make your way through them.
And for young people too who are listening, I hope that you heard that Dr. Wailoo said that his work was informed from the time he was 7. So every day we add a building block to our lives. During the conference, and your conference to me was like Sankofa, the Sankofa bird. We're looking at the past to be informed with the future. And the conference actively looked at pandemics over the years, whether it be the influenza, SARS. I'm going to let you speak to that. But what are some of the concrete things that came out of the conference in light of what we have learned from past epidemics and pandemics, and how can those things help us to navigate this present situation?
Yeah, so some of the things you learn are not entirely uplifting, but at least they give you some sense of perspective. So for instance, every time there's something this global, something this tragic, there's always blame. There is always all these social tensions that you see over who is responsible, the finger pointing. Sadly, this is part of how societies deal with these crises. And the blame is often pointed at particular vulnerable groups. You also always see the idea that there are certain kinds of vulnerabilities that become visible. And society says things like, oh my goodness, there's poverty. And poverty explains why some people are more vulnerable to the ravages of this communicable disease. We knew that before. It just becomes much more visible, like you can't ignore it. So those are the sort of negative things that happen. I could run through a whole list. The positive things is that, you know, as a historian, you realize that this story, it's a story, and it has an arc to it. It will play itself out. And the question is, which chapter are we in if this is a story? And it could play itself out in a number of different ways. So some epidemics in the past, the tail end of the story is society decides that something is wrong that needs to be fixed. Like, for instance, back in the 19th century, you had cholera epidemics, and out of it came the creation of a public health system. The idea that we actually needed to get ahead, right, to safeguard the health of the public. That's a positive story. Sometimes what happens out of these stories is just people forget. And so one of the things that came out of this conference is the need to chronicle, the need to actually for people to tell their stories so that we don't forget, and that the last thing I'd say is, I mentioned to you before we went broadcasted that unlike other epidemics where people were isolated and couldn't share their knowledge until the thing was over, we have technologies like this. so people can actually connect. And that makes this epidemic a completely different experience, but also an opportunity to connect and learn as this thing is unfolding. Where it's going to go, I don't think anybody can say, because we're still, I wouldn't even say we're in the middle of the story yet, right? We're in the middle of maybe the first half of the story. And we're waiting to see how this plays out, but we should be prepared to, if it means moving society in a more positive direction, like building a better public health system or paying attention to questions of poverty so that this doesn't happen again. Those are the kinds of things that we can focus on.
One of the things in reading about your work and even listening to you now is how you have made people the center of medicine. Your work is very people-centric. And I was looking at one of your videos, and in the introduction, the person who introduced you talked about the storytelling, not storytelling that is unscientific, but placing the narrative of people at the center of the discussion and at the center of the research. Now, having said that, one of the things too that we are very conscious about is the suspicion of people of African descent in North America, and maybe there are other parts of the world, and you can share that with us, are suspicions of medicine or suspicions of healthcare systems. We've seen that repeatedly. Sometimes we say to people during the HIV/AIDS epidemic, why is it that you don't go to the doctor? And they say, because, we've been tricked in the past in our histories and all of those kind of things. So again, how do you see and what contributes to our resistance to information around diseases and all these things? We often see them as illness of the other, not of things that are affecting us.
This is a good question, and we could spend the entire time talking about this because it's complicated. First of all, of course, not all Black people are the same, right, with regard to these questions of suspicion. But I think that there is in the Black history a sense that figures of authority have often said they have your best interest in mind, but they don't. They have their interests in mind. And medicine and science is not immune from this, right? So, and we, because what I study, there's a history of people in medicine and society who have theories about Black folks that are stigmatizing of Black people, theories about how Black biology is different from white biology, which is based on theories that are unsupported by facts, and also experiences of kind of, condescension and paternalism that when you go to the doctor, you're uncomfortable. I had an experience with a doctor recently where it's not that, I don't know if it was a race question, but his attitude was just uncomfortable to me. He spoke down to me. He acted as if I don't really understand what he's saying. And for certain people like me, I find that just off-putting. So what I do is I try to find another doctor who I can talk to. But if you only have one doctor to choose from, and that's the doctor who treats you as if you don't know, of course it's going to bring up all of these questions, right? Like, how much of this doctor's attitude is based on his views about me as a Black person? How much of it is just built into his or her view of what being a doctor is? All of these things are present in and so when you have a question about, like, should I go to the doctor, you have to grapple with all of these issues, right? And some of them are, are your concern, but some of them are built into the system. So I guess my feeling about the mistrust is that it's not a one size fits all mistrust. It can have all different kinds of origins, and some of it is me, right? And some of it is just the way physicians are trained. And some of it is deliberate and conscious kind of, talking down to people based on how they are perceived, Black people, women, etc.
The Tuskegee experiment is so seared into the DNA of Americans that pops up ever so often. Yeah.
Yeah. So the Tuskegee experiment is an interesting one because in some ways it explains, it's one example of, African American men who had venereal disease, who thought they were being treated, but in fact were being studied. And this is a study that started in the 1930s and it ended in 1970s.
Wow.
So it went on for 40 years. And it went on even after penicillin became available, right? So it's a shocking and horrific example, but in some ways, for many people, it just sort of stands in for what they think is always going on. The problem, of course, is that it's not always going on, right? I mean, when you go to your doctor, they're not, they're not going to not treat you. But if it's just lingering in the back of your mind, it will foster your suspicion or your anxiety or your concern. And those are one of the many factors that play a role in how Black Americans or African Americans in other contexts sort of like look at the healthcare system with a little bit or maybe a lot of distrust. I'm not sure that everybody has Tuskegee first and foremost in their mind when they have a cough. You know what I mean? But it does play a role.
No, you made me think about when I was about 19 or 20 and I went to a doctor and he said to me, you have to have a hysterectomy. And I'm thinking like, oh my God, that's for old people,
Yeah.
And my mother worked for the health insurance system. And I remember saying to her, the doctor told me that I need to have a hysterectomy. And she was like freaking out and losing her mind. And then she was saying, the stats of people, of women who were getting hysterectomies. I remember then going to the hospital on the appointed day that I was to have this hysterectomy to say to the doctor, I'm not going to have the hysterectomy. I wasn't even recorded. They were not even expecting me. So here's the thing. First you give me this news that I have to hysterectomy. I haven't even lived life yet. And then I show up to kind of like interrogate you about this. And I'm not even
in your system.
I don't even exist. Those are the things. There's a question which is related to what we are speaking to with. So I'm going to go to that question. And the question is, the record shows that COVID affects Black people disproportionately. Is this a race issue? If so, what kind of psychological or mental impacts Black people will face now and in future pandemics?
So great questions. Let me just point out one thing about what you said, though, about your experience, because to me, this is part of the double bind of how race and medicine works, which is that you are simultaneously at risk for being ignored and at the same time being selectively pulled in to a system that's going to give you a medical care that you don't need. That's the story that you just told, right? And to me, how you navigate that is just very complicated. How do you avoid the unnecessary surgeries? And how do you make sure, though, that you're getting the medicine and the healthcare that you need? And the system has biases on both ends. So with regard to COVID, it's really true that, in cities like Atlanta, Chicago, New York, the early data is suggesting that Black people are disproportionately dying at higher rates and ill at higher rates than the population. So what is this? Is it race? Well, it's race connected, of course, with urban life, poverty, density of living, right? So yes, race is connected to all of those things. And here's how I would say it's connected. Some people say, well, it's connected with the fact that Black people have higher rates of chronic disease or diabetes. That could be part of it, but it's more likely that what you have are people who live in an apartment building where or a part of the city that's so dense that it's impossible to actually have the social distancing that you or I could have. Like if I walk out, I actually don't see anybody on the street. I'm looking at my window. I don't see anybody on my street, right? I live in a nice suburban neighborhood. If I go down the street, I'm not coming close to anybody. I don't have to go through an elevator to get where I'm going.
Gotcha.
I don't have to walk through a lobby to get where I'm going. And also I don't drive a bus. I don't drive public transit. I'm not an essential worker where I come into contact and with more and more people. So all of the people who are at higher risk happen to be Black, but they also happen to be in the US, living in cities, living in neighborhoods, having to take public transit to get to work, and many of them are essential workers. That means I'm not an essential worker. I mean, I continued my teaching, but I use this technology to do that. So if you want to say, is it race? It's race plus a lot of these other things.
Oh, we're seeing it all the time, even here in Toronto. You know, where the conversation is the fear of being vulnerable, and also to push back about this label of our vulnerability.
Right.
That's one of the things that I find that the society now, brown and Black people are vulnerable. We're this one big group. My sister-in-law out of California the other day, she was pushing back. She said, I was a human being, but suddenly now I'm a brown and Black person prone to all of these pre-existing conditions. Yeah. And I'm so blessed then. Very fascinating conversation, or the time that we are in, of people of African descent. Mm-hmm. Where we are located on Bathurst Street here in Toronto, it's a street of legacy of people of African descent and of people of Caribbean ancestry. The late Beverly Maskell, formerly from Nova Scotia, she created her business on Bathurst Street, Maskell Beauty Supplies, much like in the tradition of Madam J. Walker. Mm-hmm. What she was also known for was her fundraising efforts to raise consciousness and monies for people with sickle cell anemia. She would have the Ebony Fashion Fair come to town. And then she also went on to be one of the founders and funders of Camp Jamoki, which allows children to just have a wonderful experience in the summer at summer camps. Now, I know the research that you have done on sickle cell anemia is very extensive. I'm also too very intrigued, and I thought it was a kind of an edgy title that you have, Dying in the City of Blues, Sickle Cell Anemia and the Politics of Race and Health. Could you comment on your research, but also to what should we know about sickle cell and its relationship with COVID?
So on the second question, I don't know terribly much about the specific connections between COVID-19, coronavirus, and sickle cell, except to point out that it is a disorder, COVID-19, that if you're already vulnerable, if you already have a health problem, your ability to recover it, but it's mostly, from what I understand, things like, heart disease, diabetes, high blood pressure, and pulmonary disorders. So fortunately, none of those exist in sickle cell disease, but that's not to say that, I think we're still going to be learning who the vulnerable people are. But how sickle cell disease sort of figures in our understanding of kind of the politics of race and health is that, the Dying in the Sea of the Blues is a book I wrote about Memphis, Tennessee,
right,
and the kind of the politics of race and health, and it has to do. I think it connects with this issue of blame that you brought up. In the early years, so sickle cell disease was discovered in the 1910s, and for the most half of the first half of the 20th century, most people thought of it as a rare disease. It wasn't linked so much to and the reason why they thought it was rare is that children who developed sickle cell disease in a place like Memphis, you couldn't distinguish the experience of infant mortality, like dying young, from the fact that a lot of kids died young. And it was disproportionately Black kids who had a higher infant mortality rate. So they had no way of saying, well, these kids are dying from a specific disease. As far as they were concerned, they were dying from tuberculosis, they were dying from pneumonia. All of these things afflicted kids with sickle cell disease because it does make you more vulnerable to a wide range of, let me put it this way, the infections that would look a lot like tuberculosis, it would look a lot like malaria, et cetera, what sickle cell appeared to be. So the point I'm making, though, is that the early years was, I ended up studying the history of how society responded to infant mortality, especially Black infant mortality. And what I discovered was that in a city like Memphis, the tendency was to blame Black people for the dying of children. A good example is Memphis sits there on the Mississippi River, and it's in Tennessee, but it's just across from Arkansas and just north of Mississippi. And when in 1934, the U.S. Public Health Service pointed out that Memphis had a very high case of infant mortality, the city leader said, well, it's not our problem. These are Black families that come in from Mississippi and Arkansas when the mom is pregnant. The children are born here, they die here, and then we get blamed. But the problem is from so this is a good example of how there's this history. Whenever there's health problems like COVID-19 or infant mortality, you want to figure out who to blame. And to me, it's a sad statement about the way we deal with health problems, that our first impulse is not to say, what's the underlying problem that's producing high infant mortality? Why do Black people have higher rates of COVID-19? Our first impulse is to say, is to try to distribute blame. So the book I wrote about sickle cell disease is how the story of blame becomes a different story. It became a different story in the middle and late 20th century, partly because of science being able to see sickle cell disease in its own right, not just as a general infant mortality problem, but as a specific kind of problem that warranted its own attention. And that's the story of like the development of testing and the development of hematology and pediatrics. But it's also the story of how Black folks, having now learned that there was some disease, sickle cell disease, that was more prevalent in their community, rallied to do fundraising, to call attention to it, and to use it as the basis for pushing for greater access to healthcare, broader community awareness. So, the Black Panther Party in the late 1960s did sickle cell survival meetings and conferences, sort of owning a disease and using it to generate public awareness. Many people might be able to look online to see a movie that was made starring Sidney Poitier in 1972 called A Warm December, which is about him as a doctor who falls in love with a young African woman. It seems like it's a story of intrigue, but it turns into a story of healthcare because she has sickle cell disease. So there's a kind of a shift that happens in the 60s and 70s where the sickle cell disease story doesn't become a story of blame and, kind of pointing fingers at the Black community. The blame doesn't all disappear, but there's a sense of ownership and rallying around and claiming something for your own, and then bringing resources to bear on providing better care for people with sickle cell disease. So that's partly what I write about in that book, was how does the politics of Black health change in that direction and what the current challenges are still.
Mhm. All the while you were speaking, I was thinking of blaming. And again, when you're talking to people and people say, "Oh, thank God, this pandemic didn't come out of Africa," because never again. It's a blaming thing. My mother of 87 years old, and I've noticed a lot of old timers say like, did it come out of Africa? Because, we had the Ebola and the SARS.
Mm-hmm.
You saw the stigma that was cast on people. You saw the stigma of new immigrants coming into the nation. And, they say, where are you from? Oh, I'm from a particular country in on the continent of Africa. And suddenly like, because Africa is one big country, right?
Mm-hmm. Right.
I mean, there's this blaming thing. In this particular case, the pandemic that we have now, the source or where we are told it comes out is from the Wuhan province. So the Chinese now, they're being blamed. And we see now the ripple of the effect of that Asian racism being directed towards the Asian population.
That's true, but to me, that this is an example, right? That sadly, blame always goes with this story. In cholera epidemics in the 19th century, it was Asiatic cholera before it was just cholera. The funny thing about this blame story today, however, is that the high rate of the number of cases and mortality in the U.S. is kind of turning the tables on the U.S. So one of the participants in this conference this weekend who worked on the history of Ebola and studied this sort of politics of blame in Ebola pointed out that the relatively low number of cases in sub-Saharan Africa, Western Africa right now of COVID-19 is actually making a lot of African nations take a look at the U.S. and say, maybe we need to impose some travel bans on people coming from the U.S. because it's the U.S. And the final spokesperson in our conference pointed out that while Americans are, some Americans, especially like the president, are trying to blame the Chinese are saying, a failed state, this is a professor named Ruth Rogaski at Vanderbilt, she said, actually, in the eyes of the Chinese looking at the US, they're wondering, how is it that you can't produce enough masks to safeguard your population? And as far as they're concerned, this is like what a failed nation looks like. So what she was sort of saying is that the blame goes in a number of different directions. We might be choosing to blame Asians inappropriately, but people in China are looking at us and going, why can't you control the rate of spread of this? It should be fairly simple, like make sure people have masks. How is it that your healthcare workers don't have enough protective equipment? Like what kind of society are you that you don't know how to safeguard your own people? So, I think when you're in the middle part or the early stages of the story, the point is everybody is looking at each other and sort of casting blame. And this part of the story will produce another part of the story. And as a historian, we're kind of attuned to, as historians, we're attuned to how the story is going to play out eventually.
Again, one of the things that we're fascinated by is like even the role of Cuba and its response to epidemics and pandemics and the progress that they've made with their drugs. Is it interferon? Anyway, the progress that they are making in medicine. And what a shame it is that we cannot tap in really to a large degree into that knowledge that is being produced and developed every day because of unwillingness of nations to work together even at a time of a pandemic. I have another question that is related because you did mention the Caribbean. And from this caller, it says, we have been hearing from leaders in the Caribbean on COVID-19. Their economies are heavily reliant on tourism. What do you see the future? How do you see the future of Caribbean nations being able to handle the aftermath of the pandemic what are the potential evolutions?
Yeah, well, that's, one of the things I often say is that I'm more comfortable looking back at the past and trying to figure out where
Maybe that's why.
things, yeah,
Okay.
exactly, right, yeah. But at the same time, I mean, as a historian, you do know that there are possible next steps in this story. I think that there's going to be a period of what you might call greater insularity for all nations. That is, because one of the things this pandemic has revealed and is going to be lasting is that the things that we all talked about, us being a global interconnected society. So you have auto parts where, the part is made in one country, it moves to Mexico, it's assembled there, it's put together here in the United States. The whole idea that people and products are moving across the world, and that made society stronger and better. This pandemic fundamentally challenges this. And so if you, as a society, are dependent on tourism from the US or from North America or from Europe, this is going to be a major challenge because the airlines have to be safe, right? Modes of transportation have to be secure, and people have to get in their head that it's okay to travel again. How you go from the shelter in place to I'm willing to go to, we haven't even got to I'm going from shelter in place to go back to work yet, let alone shelter in place to I'm going on vacation, right? It will take time for us as a society to get to that comfortable zone. So what's the challenge for Caribbean nations that depend on tourism? Well, it's that you kind of have to wait until all of these processes play out at the same time that you kind of work on things like resilience, building an economy that might actually have to begin diversifying, right? Diversifying around other non-tourist commodities, because that tourism is not going to come flying back immediately. Now, that said, the tourism will be back. I remember when 9/11 hit, and here we are in New Jersey, right? Just across the river from New York. And people were like, nobody's going back to New York City. New York City is done. People started moving out, but there were a couple of organizations, I was part of one of them, that was looking ahead at its annual meeting and said, we want to have our annual meeting 7 years from now in New York City. Why? Because the hotel rates were suddenly dirt cheap. And if you promised that you were having your annual meeting 7 years from now, so if you're a tourism organization, you start making those kinds of trade-offs. You're like, look, we can offer you this cut rate, for 6 years from now. People can make decisions for they know that this is going to be over in 4 years. They know it's going to be over in 3 years. It's the year that they don't know about, or maybe 2 years. So to me, and sure enough, we ended up 7 years later at like the Ritz-Carlton for like $120 a night, because the association had made that deal right after 9/11 hit. So I guess what I'm saying is, like, if you take a long-term view, there are opportunities there, but you have to be able to weather the storm. And that's going to be the major challenge looking ahead if you're a tourist-dependent economy.
One of the great things that we've seen come out of the CARICOM region, and I can't think of anyone that I've spoken to in the last little while who had anything negative to say about the leadership of the nation, or maybe the handling, and I'm speaking specifically now in the East, the English-speaking Caribbean.
Mm-hmm.
As the prime ministers address their nations in their daily briefings, there's a sense of confidence with the nation that the leadership of the country seems to be at work.
Mm-hmm.
I don't know if these people are also too Caribbeanist to the core. A number of them have had their formal schooling and post-secondary education too, in addition to at the University of the West Indies. But there's a different level of confidence. And it is wonderful that we have this moment because they all seem to agree that you have to grow more local, eat more local,
Mm-hmm.
go back to some of those basics that we've moved away from. Um, my mother, as I shared with you earlier, every day she says to me, the people with COVID, are they like using plenty light and sun? All of these indigenous knowledges. But in seriousness, though, there is a level of respect coming out of the region around the leadership of their countries. So we believe that there is great potential for something incredibly wonderful to come out of this experience with the Caribbean nations.
Yeah, well, I would say one thing is that, I mean, you asked about, what I derived from growing up in Guyana. And I mean, there's just this deep appreciation of the value of education
Mm.
that has always been part of my family, that I, was kind of brought up with a respect for education. And the reason why I bring this up now is that when you have leaders who are educated and who respect the value of education, they can actually draw on the knowledge to help chart a course. And, in the United States, I mean, to be perfectly frank, we're dealing with leaders who are just profoundly ignorant and uneducated. And so this is one of those times when it does really matter who your president is, who your prime minister is, who your elected officials are, because, those top decisions are going to help chart the course for not just like how you keep people safe, how you reopen a society in a very deliberate way, but also how you rebuild an economy along the lines that you're describing. So I don't know about the educational background of all the leaders in the Caribbean, but I can probably guess that they're probably smarter and they're probably, using a lot more brain power than some of the elected leaders, I won't name who, that we have to deal with here, which is why in the US, we're turning more to our governors than ever before, because there's this sense that, the from the top, you just have no idea what their ability is to really think in a complicated way about what these challenges are.
You always remind us of how located to politics is in all of this. Political people making decisions on our everyday lives. And thank you too for reminding us about the power of voting. Really important, how we vote, when we vote, and voting from the point of view that you have an influence in determining the leadership who determines how you live, eat, breathe, and sleep.
Absolutely. Absolutely.
That is huge. I'm going to move slightly to another area of your work. And it is something that North American societies are struggling with the dependence on painkillers and all those type of drugs. And I've noted that you've done a lot of work in evaluating or investigating pain. So my questions are, how does one evaluate and quantify pain? That's one thing. And is it more important to cope with pain or to cure pain?
Yeah. So how do you evaluate pain? Well, pain is one of those issues that it's impossible to really, truly evaluate. So it's not like, and that's what makes it so difficult for doctors and for society to deal with. So, because pain isn't like your temperature, right? You use a thermometer, you tell how much then you can figure out if you have a fever or not. Or blood pressure, you put that cuff on, you could tell what your blood pressure is. So there's a whole bunch of things called vital signs that doctors use. Pain, I have to ask you, on a scale of 1 to 10, 10 being the worst pain you've ever had, how much pain you're in. And then I have to trust whether you're telling me, what is real. And then your 10 is not the same as my 10, right? So pain takes you into this realm where you're really dealing with trust and communication and what's called, like I call intersubjective, interpersonal communication. And it also, therefore, is this area that doctors and our society is not very good with, right? Because, me treating your pain depends on me trusting that what you're telling me is something that I need to act on. So the history of how we deal with pain is the history of how people perceive other people. And when I think that your pain is like you're making it up, or you are just tend to be more flamboyant and you should just suck it up, then it turns out that we tend to treat people in pain worse. And in times when we think that, a good and fair and compassionate society is one that cares for the people who are in pain, then we end up doing more. And the trick question that segues into your next question, which is what should we do? It really depends. It depends on the individual. Some people, what works for them is like if you have low back pain, like these electrical nerve stimulation belts, these TENS units can work really well. Other people, medicines work well. Other people, acupuncture work well. So pain is very individualized. And some of the problems sometimes is when you think that there's a one-size-fits-all approach. Curing pain is hard because and ignoring pain is also hard. It's kind of like the two, ends of the spectrum. So what I would say is the history that I wrote is a history of why we debate who's in pain and what level of relief they deserve, and how that history is part of something else. It's a history of how we debate about who is worthy of relief, whose pain matters, whose pain doesn't matter, and what kind of society we want. And I can't hear you there.
I've noted that you made a reference in your work that whose pain is real and who deserves relief has created these stark ideologies and divisions in the society.
Mm-hmm. So there's a history of regarding, if you just sort of like move towards the question of a race, and this is part of the sickle cell story as well, because the pain of sickle cell disease is these recurring crises that are a hallmark of having sickle cell disease. And in the 1960s, as I mentioned, it's rising in importance. There's a sense that we need to care for people in sickle cell pain. By the 80s and 90s, there was this sense that people in sickle cell pain, or people who come in claiming they're in sickle cell pain, you should look at them suspiciously because they're really drug seekers, and you should cut back. So it turns out that the debate about whether people with sickle cell pain deserve relief or skepticism is part of a broader political discussion about how you regard Black people, right? And Black people in need and Black people in pain. So that story of worthiness and unworthiness is part of a broad, and what I try to do in this History of Pain book is to say, we need to have a deep conversation about why some people's pain is seen as unworthy and why other people's pain is seen as, worthy of relief. And in some ways, the opioid crisis that's playing out today is a story that's rooted in the idea that, we have aggressively treated white, rural, working class pain with medicines And the story of how the opioid crisis has become a crisis is that story. And at the same time, if you're in an ER in LA or Atlanta, there are studies that show that if you're Black or Latino, you're much less likely to get treated with pain medicines for like long bone fractures, which are very, very painful, than white patients. So you have these sort of two worlds. One is a world of people being over-medicated, and the other is a world of people being denied. And it goes all the way back to ideas about Black people being tougher and being able to tolerate pain, or basically having their pain ignored. And this is layered upon the story of the politics of pain.
I want to go back also to vaccines. We're moving to a point where there is that rush to create a vaccine. I know that we welcomed the work that is being done by the Dr. Corbett in Maryland. Some of these folks have been floated on us doing work in the area of vaccines. But once again, what do you see the messaging? What do you see that messaging? What does that look like for us to have trust in the vaccines that are coming forward? Are people going to go with the herd effect in this time? But, you know, am I going to drink Kool-Aid and this is going to cure me because it's a vaccine? I don't know. But, and again, this morning, throughout the day, I'm really mindful that people are pushing back on vaccines. I don't want to be vaccinated. So I want to come back a little bit to what's your thoughts on the vaccination process and the rollout process of that?
Yeah, well, it's always important that when you actually have a vaccine, or when you have an effective way of intervening in this COVID crisis, getting people to buy in is going to be the challenge. And the history of vaccines is the history of these kinds of controversies. One thing I'd say, though, just to say one thing about where we are, because we are really, like I said, in the first half of the story, we're still at the stage where we're grasping, right? We're grasping and trying to think about when and where and how this will end. And right now, you know, one of the nice stories we tell ourselves is that this will end with a vaccine, right? And it is true that there are some illnesses that end with vaccines. Polio is a good example of an illness that ended with a vaccine. If you offered people polio vaccine today, everyone would take it, and everybody has to take it because that's like mandated. Or, you know, there are stories that end that way. Then there are more vaccines like the annual influenza vaccine. Sometimes it works. Some years it works better than others, right? So there you have a story where the vaccine doesn't end the story, you know. Then there's the stories of illness where vaccines never happen, like HIV/AIDS, another virus, right, that came along in the 1980s, similar kinds of public health crises. Of course, sexually transmitted disease, not communicable in the same kind of contagious way that, you know, this is through droplets that you breathe. Never had a vaccine. You know, decades and decades of trying. So one of the questions is going to be, not only can we create a vaccine, but which of these models is this one going to? But in the meantime, you know, we're grasping. Well, maybe if it's not a vaccine, maybe Lyme juice, right? Maybe if it's not a vaccine, maybe this other disease, hydroxychloroquine. Maybe if it's not a vaccine. So we're still early and we're still grasping. If a vaccine does come out, I think, and if the early suggestion is that it really is effective at preventing you from acquiring and developing, I mean, I would be hard pressed to argue that, like, you should, whatever your distrust of vaccines, you will take that vaccine, right? Because the consequence is that you have to stay in your house, right? Or, you know, the other vulnerable population is the nursing home population, right? I mean, obviously you would vaccinate every single person in a nursing home because a vaccine, even if there's some small element of danger, like there was one batch of polio vaccine that was made in the 1950s that was a bad batch that ended up harming children. And it was a black eye, but the vast percentage of vaccines for polio have been highly effective. Are you going to get rid of all vaccine skepticism? No. People will, but in this instance, the dangers to like the elderly is so dramatic that of course, if we had an effective vaccine, we would provide it to all of the most vulnerable. Now, the key is, I'm not sure how quickly we're going to get there, or even if we will get there, because we're still in the first half of this story.
Great again for reminding us about our efforts with HIV/AIDS, and didn't have a vaccine, but we've developed so many resources so people can have a better quality of life. So that's an important thing to remember or to be mindful, because sometimes in this whole newness and oh my gosh, this thing is falling on us, we have to stop for a minute and think again, what you did at the conference, what has happened in the past that we can kind of draw on now to cope with whatever going forward. What's the student movement doing, and how have you seen students and students in the university responding to COVID?
So,
credit for that. That's another question that's floating here. Yes.
Okay. So that's a really interesting question. It's a challenge because, of course, the students dispersed. Right. So at midterm time, early March, the university sent students were home, but they haven't come back. So we have been online in teaching. The students were now entering finals. So one of the questions is, will students be coming back in the fall?
I was about to ask you that.
They're actually waiting until mid-July to make that determination. I mean, one thing that is they're taking into consideration is, of course, most of the sad cases of death are people like my age and older. Young people seem like they're more likely to be transmitters of this disease than they are to be sick from it or die. So if they bring them back, how do they take care of them? And one of the real interesting questions the university has to grapple with is, if they bring them back, what's the implications for me if I have to teach in a classroom, right? So it's really protecting the staff and the faculty and the people who work at the institution from the students, because they're relative. So those are the things. So the student, in some ways it's taken a little bit of a bite out of the student social life, the student political life, the student activism. I don't know what's going to happen, but that's, I think, generally true, right? Which is, it's hard to mobilize when you're dispersed. And like I said, the one mechanism we have is this technology to connect people.
And this technology, for those who are online, people who are tuning in, the technology that we have right now has allowed us to connect with Dr. Keith Wailoo, the chair of the Department of History, and he's also with the Woodrow Wilson School of Public and International Affairs at Princeton University. And Dr. Wailoo, I'm also looking at the comments too that are flowing on the screen from Kathy Hope. She says, interesting perspective and very informative. And I have someone Dalton Higgins, and he also wants to know, he says, I find that there seems to be a built-in, and we go back to this whole mistrust of the system. I find that there seems to be a built-in mistrust of vaccines by our community, fueled by conspiracy theories. Not sure where that comes from. I think he's asking you to comment again on that. And I guess in your comment on that, what type of messaging, what messaging have you seen has worked to be effective in terms of getting information out, not just to the wider community. And I'm going to speak now specifically to people of African descent.
Messaging. So, you know, there's, this takes you into a realm of kind of like social psychology, like how does information get out such that it gets traction? And it's always been the case that, like, when they were trying to spread breast cancer awareness in the Black community, it was through beauticians, right? So there are many studies that were done when I was living in North Carolina about the role of barbers and beauticians in just kind of like shaping public awareness. And so one of the things you have to think about is who are the trusted people in authority in different communities. Because it's not the case that people go, if you already have respect for certain kinds of individuals, then it's those individuals that you might end up turning to in moments of concern or crisis. So one of the things that one should think about is if you already have respect for your elected officials, then you will turn to them when these kinds of issues emerge. But if you don't, then you're going to not pay attention to them. So the question we often try to study is, is it ministers? Is it, you know, just to sort of turn the tables a little bit, in HIV/AIDS, you know, one of the groups that did not stand up to take ownership of HIV/AIDS in the Black community were Black ministers, right? Because they thought of it as connected with homosexuality and a lot of issues that they didn't want to grapple with in their congregations. And it took them a number of years, far too long, to get over that as people were turning to them for insight. So it cuts in a number of different ways, this question, but there are already existing members of, you know, in high standing in communities that can help shape public awareness, and this is the time for them to sort of get out front, to say, well, look, you know, it's not unlike what you're saying about the leaders of Caribbean countries who were saying, look, okay, you know, tourism is not going to show up next month, right? Or 6 months from now. So what do we do in the interim? And how do we begin to mobilize ourselves for what is coming next? You're a member, I mean, you're the person, right, who you're a respected member of your community. And so to me, it's these kinds of conversations that are doing the job of shaping the way in which we, that respected people are helping to sort of chart the course in the months ahead. So that's what I would say, is identifying who those people are and bringing them into these conversations about what their role is.
And again, for those who are viewing and for those who will continue to watch this online at adbcc.org or on our Facebook or social media platforms, it's really important to remember that as community organizations, we have great platforms for advocacy. We have a great platform for communicating information to people. It reminded me too of the time in Zimbabwe, where it was really important for people of African descent when they traveled there to explain to people, once again, HIV/AIDS, everybody's going to get it. But then the trust factor came from, here were Black people from North America speaking with them, as opposed to the traditional NGOs going in with that information. But the most important thing here is that community organizations, we can definitely play a role being on the forefront in our communication with people. One of the things too that we are very mindful here in Canada is that there is no coverage. There is no reference to how we are responding to COVID in your US media. Is it a question of our universal health care? We're socialist. I don't know. But I mean, the government or the Americans will go everywhere in this world to find this example of best practice. And you kind of think, isn't there a border that separates us? but we are never referenced or mentioned as someone who has straddled both countries. What's your take on that?
You know, that's a really good question. I don't, I think that Americans are self-absorbed, for one, and only reference other countries. I think that politically it has become very fraught and dangerous for people to reference other countries for positives. So, because, you know, there's this kind of like, the whole critique of the Canadian healthcare system it came out of like the Clinton era, where there was this way of bashing the Clinton era health reform by saying, oh, he wants to turn us into Canada. We're not Canada. And so there's this kind of this history of every time another country's exemplary healthcare system is brought up, it always leads to criticism, not only of the other country, but criticism of the people who are bringing up the other country as the example. And so from my perspective, Americans have completely shied away and from even thinking about other models of healthcare, because every time you bring up Germany or you bring up Singapore or you bring up China or you bring up Canada, people are it's this kind of hyper insular, patriotic, jingoistic, you know, response. So that, I think, is a big part of why there's just no coverage, except every once in a while you'll see how are these other countries doing it? Like, you know, how did they manage to keep their cases down? But it never really adds up to a whole lot in our context anyway. So I don't have a deeper answer other than it's something deeply rooted in Americans' kind of like American-centric way of thinking.
And as we move to the end of the program, I'm going to ask you what are your thoughts? What is that statement that you would like to share with people in terms of their everyday lives? What are those tips? What is that wisdom? What is that thing that you think, oh my gosh, if only given the opportunity, I just want to say that. And then again, health is a universal thing. It affects all peoples. But I want to know today, what is that messaging that we can give to people of African descent as they go through this COVID period?
Well, I think that, you know, maybe two quick things. One is to ignore many of the stigmatizing, blame-oriented, I mean, this is sort of like what Black people have been doing, you know, forever, which is ignoring the blame and ignoring the stigma and forging a path ahead in the name of survival. The other thing I would say, though, is, and it's not specific to Black folks so much as realizing that amidst all the isolation and the patience that it's going to take to endure this, that there's a new kind of community building that things like this are doing. That is, that what we're doing is reinventing ideas about how we're connected to each other. So you mentioned community organizing, like understanding that, you know, that your community is what's going to help carry you through this. And so it's not like the global economy that's going to save us. It's like the resilience of our communities. And so it's community institutions like yours. It's connecting at this intimate level. It's relying on each other for these kinds of support. To me, this is going to be ultimately one of the stories about what happens below the radar in this pandemic. And it's ultimately, I think, the thing that's going to carry us through.
Your statement, when I said earlier that your work is people-centered, and you've brought that right home to our conclusion. And again, reminding us that we we can draw from our strengths. We can look inside. We don't want to be insular. It's not an insular thing, but we can draw from the strengths of our communities, from each other, in terms of navigating this. We don't have to be dependent because we have gained independence to a large degree. So I really thank you for reminding us as a community of people of African descent today in this segment, how important it is to believe in ourselves, to attest and affirm our resilience, and once again to demand the respect that it is due for us as we navigate science and medicine. It has been an incredible privilege today to speak with you. I feel that I've known you for a million years, but this is all good. And again, today we've had the great opportunity to speak with Dr. Keith Wailoo, Chair of the Department of History, Princeton University. He's the author of several books, and I am pretty sure that a different bookless bookstore will be stocking his books going forward, because they are of tremendous interest to us, not only at this time, but they're also great reads to inform us. Want to say best of health to you and to your family, and looking forward to speaking with you again, and maybe even having you in the new normal going forward, in the flesh, here in this great city we call Toronto.
I would look forward to that. And thank you so much. It's an honor to be with you today.